All right, so thank you for attending this morning. We really appreciate it. We have our introductions. These are our disclosures, which aren't many at all. This is what we hope you guys are going to learn today. If you guys can't see that slide, feel free to take a minute and come over this way. There's a decent number of seats so that you can see the slides. Feel free to get up and move over this way if you want to. What?
I was gonna like write on it or something.
Oh, no. All right, anyway, I'm going to talk about how we got here. Like I said, we're talking about a retrospective chart review, right? So how did we get to that place? So we all know that the pandemic was challenging in healthcare for sure, right? Like that was a painful couple of years in the clinic setting. But there were a couple of bright spots. Mandy and I work at Shepherd Center, and all of our outpatient clinics closed for a decent amount of time, but our seating clinics stayed open to do wheelchair fittings and trainings for those who would come, because otherwise they wouldn't have gotten their chair. And then we did some limited evaluations. So it was a reduced volume. So it allowed our therapists, and we were grateful for the opportunity to address, take on some of the projects that had been on the back burner for the longest time. So Mandy took the lead in overhauling our pressure mapping protocols. We realized we weren't using pressure mapping to its full potential. Like we weren't inputting images we use Epic as our documentation system. We weren't inputting the images into our documentation. We were inconsistent on, if, why, and how the numerical data from the pressure mapping was reflected in the documentation. So she consulted with Sharon and Dr. Steven Spriegel at Georgia Tech, who have vast wealth of knowledge regarding cushions and pressure mapping, and looked at a bunch of online resources to help update our BodyTrack FSA software protocols. So she developed a new pressure mapping protocol and improved our documentation so that it was more clear. She spent a lot of time on it, and it was awesome. Little did we know that was just the beginning. We were going to have an opportunity of sorts coming our way that would allow us to continue our process improvement, but also answer some questions and create so many more possibilities. And I'm going to have Mandy start that story.
All right, you guys can hear me okay? All right, so like Chris said, after the deep dive into pressure mapping, we updated our protocol. Like there were just little things that we weren't all necessarily consistent on, like making sure to capture a full row of stencils around the pressure mapping image consistently, that sort of thing. So we did that. And our new protocol included new documentation procedures, which you all know how fun it is to get clinicians to change their ways. So that was fun. When our first iteration of that was
So that'll teach me a lesson about accessibility, because we could all use it right about now. In our inpatient population, there were actually 15 people who were in the previous pressure injury population, right? So they had had a pressure injury and they'd gotten it healed up, right? Shepherd Center did a good job. They got that cleared up. They probably got the pressure injury right away. Maybe they got it in transport, maybe they got it, whatever happened, it got cleared up. And now they're sending them to seating clinic to make sure they're on the right thing to be taken care of, right? Well, what about the rest of the people, right? The other 17 people? Well, they were predominantly sacral pressure injuries. And again, that's not so surprising for an inpatient, because these guys, they're early, right? When did their pressure injury happen, right? Maybe it happened in the ambulance. Maybe it happened first thing on arrival to the hospital, right? Those probably aren't sitting acquired pressure injuries. Now it's the sacrum, it can be, because your sacrum is getting beaten up all the time. But that's a more common location for that cohort. It's pretty different from what we saw in our 101 outpatients. 26 of them still were previous pressure injuries coming in to take a look at what was going on. But the rest of them were predominantly ischial pressure ulcers, right? We still had some sacral, but the ITs were the most common location, right? So you're looking at a different thing depending on which cohort you're dealing with. Those are probably your sitting acquired pressure injuries. Woohoo! We have slides. I have a clicker too. See, look.
Don't do that.
I tried
You're
to
going
make the next one.
backwards. There you go.
All right. I just want to click it and see what happens. It's exciting, but nothing's happening.
I'd stop.
Are you clicking for me?
No, click for you.
You're going to have a hard time because you're not going to be able to keep up. I'm going to have to stand here by a computer. It's going to make me crazy. All right. So now I want to talk about what happened when the people came in, right? What did you guys do with them? So there were 16 people who came in, and the clinicians took their history, listened to their story, and evaluated their current seating system and said, you know what? You're in the right situation. This is the best seating system for you. Maybe the problem had nothing to do with their seating system, right? And we're going to talk more about some of that situation in a few slides, because I have slides now. But before we go on to the rest of the population, I want to know from you guys, when somebody comes into your clinic, how many systems do you try? How many cushions? How many different configurations do you guys try out before you send them home? A lot. 2, 4, 10? 3 or 4? 5? You guys have a lot of time. That's awesome. So what I'm about to present, you have to bear in mind, this is what was documented. So, right, if something was tried and scrapped right away because it totally didn't work, I don't know how it works. I don't know if that ever happens, but we only worked with what was in the chart. So 44 people, I think that's a 44, my screen is really small, tried one configuration. And they said, yeah, either this is it or we're going back to the original. Another 50 some odd people tried 2 configurations that were documented. And 20 people tried 3 or more. So, yeah.
Were they tried on during the session, or was it over an extended period of time?
This is all within I guess it's 1 hour, within the 1 hour seating evaluation. And these are ones that were tried and pressure mapped. So we were looking at things that we had pressure mapping data on. And these could be a new cushion, this could be a modification, and we're going to talk in a little bit about the modifications that were done as well. So these are all the different alternative configurations that were considered. And it doesn't mean that you went with the last one. So they might have tried 3 things and decided, hey, it was actually the first one that was the best of these. So what did we do, right? What were the interventions that we went with after all that? Well, there were 23 people who had no changes, right? And like I said before, maybe after hearing the history and looking at the wheelchair configuration, the clinicians decided that what the people really needed was some education about pressure reliefs and weight shifts. Maybe they decided that their pressure injury was related to some other sitting surface. Maybe they needed education about their toileting practices or where they sat in the car or their bed at home. Maybe they needed to learn about how to self-correct their posture. So what else did we do? Well, 46 people went home or were prescribed a new cushion, and that was it. So these guys would have been fine with Amazon.com. Oh, come on, I was waiting for a dagger to be thrown at me.
It was a little delayed, but it was there.
Okay, no, that's not actually true, right? It took a while to come up with the right product, and we'll talk some more about what people ended up with. There were 45 people who didn't get a new cushion. Doesn't mean they didn't get a new intervention, but they didn't get a new cushion. 45 people. I don't know about you, because you guys do this all the time, but I was really surprised about that. So some of them had adjustments made to their original cushion. Some of them had adjustments made to their wheelchair, and some of them had adjustments made to both. And then there were 20 people who got new cushions, as well as adjustments to their wheelchair or adjustments to their cushion. So what do I mean by adjustments? Well, the most common adjustments that were done in this clinic were underlays. And as I get talking about this, and we're going to come back to this a bit later, you have to understand this is one clinic, right? And everybody does different things. And I'm going to ask you guys a little bit about what you do, because I'm curious to know how much of this is what people like to do and what are patterns and habits. But so they do a lot of underlays, okay? And one of the most popular ones were the, wow, brain farts, were the, thank you, interior base wedges, right? And so in all of these adjustments that I'm going to talk about, there are two main goals, right? You want really good contact area. You want to support the body's weight over as much surface as possible, because if you spread out that contact, you're going to reduce the pressure at the high risk locations. So that's one of the goals of all of these adjustments. The other one is putting people in a good posture, a posture that's functional, right? And so the anterior base wedge can be doing both of those things, right? Maybe the person wasn't making good contact with their thighs. Perhaps their wheelchair wasn't set up well. Or maybe it was set up well, but their posture has changed over the time since they were last prescribed. Maybe it was set up well, but they bought some new shoes. And now their thighs aren't making contact anymore. So you need to figure out how to make contact, right? So that's one use of the anterior base wedge. You might also want to be thinking about their posture, right? You want more stability. You want to prevent a posterior pelvic tilt, right? So that's another way you're going to use it. You have to be thoughtful, because if they were making good thigh contact in the first place and you raise it up, you might be increasing the pressure at the ischial tuberosities. But if you do it with some thoughtfulness and you're attentive to how the person's sitting, this can be an effective intervention. Another one that was used frequently was a sacral cutout, which apparently is a strange name because it's actually a pelvic cutout. So it's a cutout underneath the pelvic region, right? And if you do this underneath a cushion that is deformable, right? I think I have a picture of it. So you put it underneath the cushion. Now that cushion can change its shape. You can get more immersion and envelopment, right? For somebody who isn't getting enough immersion and envelopment. So that was another intervention that was used. Then there were wheelchair adjustments. If you remember, we had a lot of people with tetraplegia. We probably had a lot of power chairs. So the back supports were adjusted, right? You can move them up and down. You could change how far back they are in the chair. You might be wondering, why are they wrong, right? Who set up this chair in the first place? And again, it might have been set up poorly, or maybe it was right when they left a couple years ago, and now their posture has changed. Maybe they drove it into a wall. Maybe it's somebody at home got a new set of tools and they were really excited to use them, because I know that's how I feel when my tools show up, right? And you're doing that with the same goals. You're trying to make sure that the body is supported on different surfaces, not just the seat. You want the body supported on the back, on the feet. So you're going for those same goals. You could do that with the lateral trunk support and the lateral pelvic supports. You're doing that with the lateral thigh supports. So we did adjustments to all of these. The back support was one of the most common, as was the footrest. Because again, if you're not supporting the feet, all of that weight you could be supporting on the feet, you're now supporting on the buttocks. So you can adjust the height, you can adjust the angle, depending on the chair anyway. So now I want to talk about cushions, right? We did replace cushions for a lot of people. Obviously, it was a cushion evaluation. Most people probably came in thinking they're getting a new cushion. So we looked at what cushions we prescribed. And again, this is going to be the type of thing that depends on what clinic you go to. People probably have favorites. And so I was curious, do we prescribe the same thing? And there was almost, I think it was almost 20 different cushions that were prescribed over this cohort. And so then I was curious, right? Who got just a new cushion, right? I don't know about you. I wear sneakers most of the time. I've been wearing the exact same sneakers since 2012. I bought them before a trip to London. I get the same model every time. So who came in and just got a new one? And the answer was basically nobody, right? Everybody, if they came in for an evaluation, they switched cushions. And it's not, I guess, maybe it's not surprising, right? They came in with a problem. People came in because of pressure injuries. And then I was curious, right? Was there a progression? Did everybody go from cushion A to cushion B and then cushion B to cushion C? And that's not how it worked. We had a cohort of people who moved from a fluid-based cushion to an air flotation cushion. And then we had a cohort that moved from an air flotation cushion to a fluid cushion. People moved from honeycomb to air, and people moved, I can't think of all the examples, but there was no pattern, right? People can move in any direction. If they stayed within an air flotation cushion, they moved from a low profile to a high profile, but people were all over the place, right? There was no one right cushion for anybody. And then we tried to look, right? Were there patterns of who got what cushion, right? Did everybody who was Dutch get a Vicare? Where are you? And there were not a lot of patterns in that either. The only patterns we really found had to do a little bit with air flotation and age. So our older participants were more likely to get air flotation. So the average age on air flotation was about 50, on fluid was about 45, and orthotic offloading was about 40, right? And that gets interesting, right? Is that a question of who needs these cushions or a bias in who we choose to give them to? Don't know. And that comes down to the second half that we'll talk about, which is we didn't measure outcomes in terms of how people did in terms of wound healing. And I'll continue to come back to that. The other thing was that there were more people with tetraplegia who ended up on air. So that was really the only patterns we found. So the other part I want to talk about is pressure mapping, right? Because that was the point of the study. We wanted to know, do the clinicians use pressure mapping, right? We know they physically use it, right? They put it out there. Oh, I don't know if Barb Crane's here, but I needed a picture of pressure mapping, and that was the only one I could find from a conference like a decade ago. So wherever you are, thank you. So do they use it, right? They put it out there, but does it impact the care they provide, right? Because it's a lot of time and a lot of effort if it doesn't change practice. And so we looked at that. And the first question we asked was, well, what about these people who had no changes made, right? Did pressure mapping influence that decision? And I can't get inside the clinician's heads. I'm not sure I want to. I'm a little scared of what I'd find. But I can at least look at the interface pressures of the people who had changes and the people who didn't. And what we saw is the people who had changes made had a peak pressure index, and you remember that's an average pressure around the peak at the ischial tuberosity of about 110 millimeters of mercury. The people who didn't have changes made were down closer to 75. So this says to me that the clinicians were using the information from the pressure mapping to decide, hey, maybe these systems are doing okay. Maybe the interface pressure isn't the problem. The folks who are coming in, maybe they're already on the surface, it's doing okay, maybe we have to change something else. The other question we asked was, did their interventions do anything? And I really want to know if their interventions helped heal wounds. And so when one of you writes me a big fat check, we're going to study that. It's going to take 5 years, maybe more, and we really want to know that answer. It's a really important question to ask. But in the meantime, the question we were able to ask was whether or not their interventions were able to reduce the pressure for people, right? Because you can ask that much more quickly anyway. And so we looked, and the starting pressures for people on the systems they came in were around 100 millimeters of mercury. And when we changed those systems, got them a new cushion, added the wedge, moved the backrest, adjusted the foot plate, we reduced the pressure to close to 80 millimeters of mercury. The average change for an individual was 22 millimeters of mercury. Give these guys a round of applause. They did some good job out there. So what? Other than my DPT students getting to graduate, why does this matter? That was a ton of data. I mean, 133 medical charts. And you guys see these all the time. You know how much that is, right? Well, first of all, we learned that interface pressure mapping informed decision-making. And the interventions reduced pressure. I think that matters. We also confirmed that there wasn't one consistent cushion that met everybody's needs. You know, I tell people that all the time, and I think they look at me like I'm crazy because they don't want that to be the answer, but it was nice to see it confirmed in practice. It also wasn't always the cushion, right? quite often the cushion wasn't the answer to the problem. We also need to remember to consider other interventions. And this is the chance for you guys to help me out. What other interventions are you guys doing pretty frequently that we didn't talk about? Is there anything else you do when you don't change the cushion, or in addition to changing the cushion? Can you run over there with a mic so she could say that again?
One thing that comes to mind is also looking at their kind of physical presentation of posture, range of motion, strength, activity to figure out, is it maybe how they're using the chair versus the chair itself, or likely a combination of that?
Yeah, absolutely. And I'd imagine, and these guys can probably speak for it, that factors into all of these decisions and interventions that you've seen, and was possibly part of the reason for some of the people who didn't have changes made, and some of the education that went in as well.
Did everybody hear that? One of my favorites is Robin Skolsky has a story about a guy who came in for all this pressure mapping and it ended up saying that he bumps up cement stairs every day to get up to his apartment and bumps back down them in the evening. It wasn't the cushion. And one of my other favorites is when people come in and they're wanting their cushion evaluated and you find out they get out of bed once a month to go to doctor's appointments. But anyway.
Thing about dialysis, I have a lot of hemodialysis people that get on those dialysis tubes. They buy it's not covered by insurance. So getting something under that dialysis.
Were these all manual wheelchair users?
They were not. I don't have the number, but I think we were actually more power wheelchairs than manual in this population. The education side, for sure.
And we do use pressure mapping to justify recline being added onto power chairs. You know, we use the data to tell insurance this is why they need it. The tilt is not doing the job by itself.
I think there's a what?
Talking about other surfaces, certainly, and you get a picture of a shower chair. Another thing that I've encountered many times are ineffective follow programs where someone's sitting on that surface for long periods of time. So maybe that consideration that needs to happen there, or even a change in diet, so it can maybe not even be the surface. But
I'm going to take one more and then move on because I know Mandy has more to present to you guys, and we've had our timing's been really messed up today, so I'm going to take one back there. And yeah, what I'm really hearing, from you guys is, number one, like we said, it's not always the cushion, and you guys are detectives, right? You guys are really spending your time not just evaluating the cushion, but working on a root cause analysis and trying to understand the background of this person as a holistic individual and understanding their life so that you can solve the bigger picture problem. And that's a lot of work. And that actually relates to where I wanted to go, which is documentation. right? You have a lot to document in this. You're not just documenting what you tried in terms of the cushion, but you're documenting a lot about this person's life. And you're doing that, to communicate with their other caregivers. And you're doing that for continuity of care so that the next time you see them, you can relate back and remember what was going on last time. And you're doing that to support researchers like me so we could get something useful done. And so I'm going to let Mandy talk a little bit more about our experiences with documentation and how much fun it is.
You can also go back and see what recommendations they haven't followed through with. But anyway, all right. So our initial documentation that we started after we got our new protocols, pros, it was easy to compare quantitative data and images between cushions and adjustments, great for client education, saves time when looking into past encounters and interventions. Cons, the paragraph form is really kind of painful. If you're trying to be quick in a session, the client's chatty, you're just trying to figure out what year this equipment was provided. So that was a con, and it can be easy to forget key elements. I mean, some of these notes we looked through that didn't make the 133 cut is because the clinician forgot to put what kind of wheelchair they were sitting in. I mean, it's easy to forget if you're trying to make a story paragraph form. So our new documentation template is a lot of fill in the blanks. It just helps us not forget things. Let's see. Over the course of reviewing our data, we were still collecting data with patients, so we added these components to our documentation. Let's see. I do want to be clear, we still use APSO notes. It's important. You can't capture everything in a click box. There's stuff about caregiver interactions that you need to get onto your next clinicians. There's stuff that isn't reflected. There's crazy stuff that you could never anticipate. But using the fill in the blank model has really helped us. This one, I know you can't read it, but it includes information about equipment, when it was provided, who provided it, wounds, what's the history of wounds, what stage was it when you saw them 4 months ago, kind of thing. The client's pressure relief, what sitting habits they have. We have a section here for where are they sitting every day, how much time are they spending with the head of the bed raised, how much time are they spending in the car driving for Uber. We see that sometimes too, but it's still the cushion. So the pros of our new documentation templates, still easy to compare images. You can still save time when looking into past visits. You can actually save a lot more time. Find situational information quickly, like how long they do sit on their equipment for a bowel program. That is one of the questions on our form. It's harder to forget to document things, and it helps ensure we capture data that we need for specific charges. Like if we're going to charge an evaluation, we know we got all these things. You don't have to pick through, did I get this, this, and this? Really the only con we've found so far is it's hard to get us to change, and it's a process, but it's not necessarily a con, it's an opportunity, and we're getting there. Oops, my second case example isn't on there anymore.
Yeah,
No, it was the one at the very end. Is it totally gone?
I don't know. It might be. I'm sorry.
Okay, well, I'll just talk through it. We had another case example, and I don't know the specifics of it because I didn't write it in my notes here, but long story short, we went over 4 or 5 different cushions. I wish I could show you because we were able to compare peak pressure index. We were able to compare contact area with these like 5 or 6 cushions. The guy in the end, I mean, he's super bony guy, super bony, and not real consistent about his habits, weight shift habits. Also had a hard time like telling me when he got his cushion, when the wound started, that kind of thing. I've known him for a long time. We ended up going with a Java cushion initially, and there is, when you get the presentation, there is pressure mapping data on the Java cushion. We don't typically pressure map on offloading cushions, but we did for him because it was, we just want to make sure, he's so bony. I didn't want to be putting too much pressure on anything else. But so that was our, yes. Thank you. Okay. Okay, so this is your reminder. Please look under the cover. You might think you know what's under the cover, but sometimes you don't. I'm sure all of y'all have fantastic stories about other things you found, but this was one I took a picture of and was able to dredge up. Okay, so 45-year-old male, T12 spinal cord injury in 2009, rigid manual chair. This was the J2 Frankenstein cushion, and a right IT wound. This is just all the data in our template. We do add images of the wounds when we can. Just easy to look at, easy to find what's happening. Another thing that we added to our documentation that was super helpful, we learned the hard way. It was kind of hard to tell in our old notes what order we did stuff in, because we just say we changed this, this, and this, and then there's these images, and well, what did we do before that image, and what did we do before that image? So we make sure we cue ourselves. What was the first adjustment made? Was the pressure mapping after that? Was the second adjustment made? Was the pressure mapping after that? So that's been really helpful too. So these are just his images, the different cushions that we trialed. I think we did more than this too, I just didn't include it all. So the current cushion, the J2, the Rojo HP, definitely trending in the right direction as far as peak pressure index went, but just didn't love it. He tried the Java cushion over the weekend, which I may have gotten in a little bit of trouble for, but I wanted him to be able to see it. The area to the left of this image is what was kind of concerning to me. He's so bony. And so I contacted Ride and they talked me through, they talked me through everything. And we ended up doing a custom ride for him, and got huge support from Paula Mayberger and from Ride in general, and our suppliers. And I called him yesterday, and it's looking good so far. So that's, it's just another example of our documentation and how it's helped. I guess next.
All right, so remember we're just talking about a chart review, a DPT student project, and all these things came to light. Shepherd Center is starting a new Center for Advanced Rehabilitation building. So we're starting construction on a building, and in that building is going to house our current research department and a new innovation center. So our department, our Assistive Technology Center, is going to be an integral part of the innovation center, and so we're on the ground floor of figuring out how and all the components of that and what that's going to look like. But with this study, it brought to light a lot of areas of research and innovation that we could explore given what we found out from the study. So one of them is design opportunities. A lot of the adjustments that were made were adding anterior base wedges and doing this sacral cutout foam underneath, usually air flotation cushions. Do any of you do this a lot, frequently? Show of hands. Just saying if we're the only ones that do that. But so in regards to innovation, so we have documentation. We see, indeed, we do these a lot. It's not just assuming it. We saw it through this chart review. And is this an opportunity that was identified that we could have cushions that can incrementally increase the front seat height a little bit if you need it to improve, the footrests don't go low enough, you need to improve your thigh contact area, or you need to induce a bucket for postural control. Can a cushion increase the rear seat height too, so you don't induce that slope? You're not increasing that slope more than you want it to. Is that an opportunity for design? Is there an opportunity for cushions to have a sacral cutout option to be incorporated into that cushion as well? Or that you can take out a portion and achieve the same effect without having to add a piece of foam under there? So there's some design opportunities that we came across there. Non-cushion positioning interventions. We're always on the search for preventing posterior pelvic tilt, right? And there has been some on the market, but is there an opportunity to design one that's coded and is affordable? So that's something as well. And then clinical partnerships with industry and academia to inform new design. This is part of what I'm grappling with, how to move forward in our innovation center, but I don't think a manufacturer or an engineer would be able to make use of the data we just found through a chart review. One way they wouldn't have access to a chart review, or the clinical application to what we did. Like there was, the clinicians, the practice would provide needed information to help improve product development, to help them meet the needs of our clients. So how can we foster that collaboration more between clinic and manufacturer and engineers? to better meet our clients' needs. So that was some design opportunities that came out of this chart review. Research opportunities for sure. Sharon mentioned, can we take the next step? Did the interventions we found actually help heal the wounds or not? We don't know that. But that's certainly a research opportunity. Obviously, people were sitting on stuff that didn't meet their needs, right? So how can we, is there an opportunity to figure out how to improve our interventions to get to these people sooner, to address their changing postural needs and their body changes and the equipment failures or equipment problems sooner, so they don't wait until the whole world is falling apart and the kitchen looks like that before they come see us, right? So there's an opportunity there. Policy for sure, our industry is in no shortage of need for policy changes, and we all, I think, know that, Julie. But more than half the people left without a new cushion. Some people just needed education. Some people just needed changes to the seating system, but some people weren't eligible for a new cushion and we couldn't do anything about it. And we have the 2 to 3 years to replace a cushion, but there's also studies that have been done on aging of cushions, and we know that some materials fail quicker than others. Some people, and on the individual level, some people use cushions more actively than others. So some people's cushions fail quicker than the next person's cushion. So is there an opportunity to help drive policy change and see if we need a different approach to funding or different types of coverage situations, right? So it brings that to light too. And then documentation, right? So we went through an iteration of documentation, right? We went through like the whole paragraph form. We've learned through this chart review. We now have more of a template form, adding some free text as well to make it easier to make sure we're accurate, and that if we do this ever again, we won't have to take as much time to do this. And documentation has 3 goals, right? It's communication, continuity of care, billing, legal protection. But in something to think about in the future and innovation is artificial intelligence is here, and it's going to affect all of us if it hasn't already, right? So most people are aware that Chat GPT, most of us, maybe not all of us, but there's also the ambient clinical intelligence is the future medical documentation. So, and hopefully it's HIPAA compliant. But it listens and summarizes. So it can listen to our conversation and then summarize it in the document. How cool would that be, right? And looking forward even more is there's the natural language processing that can take an unstructured interview and take out the relevant information and put it into a structured format. It's going to be able to predict our ICD-10 codes out of our conversation we have with our clients. How cool is it going to be when it can not only put our conversation into note format, but also pick out, maybe provide us solutions as well, given what we were talking about. Maybe it will actually not only provide us solutions, but also prompt us to say, hey, you also need to look into these things. Given what you just did, these are things you're missing, go back and figure this out. Like, that is the future, that's the innovation, that's what's gonna save clinicians time, right? We spend so much time in this industry documenting, more time than we spend with the patient sometimes. So if we can get that out of our hands, now we've come full circle and we can spend more time with our patients, spend more time trialing more new equipment, giving them more time to trial the equipment, all sorts of great things. So just from embarking on a DPT student project that involved a chart review, so many things were learned and were brought to light. Most importantly, is chart reviews are extremely, extremely painful. And it was a great way to convince us to change our documentation. But it also taught us that doing a chart review exercise is an effective way to identify our clinical questions and needs and what further research and development is needed to address and answer them. So overall, it was a great exercise. It got some students to graduate and we learned a whole ton about it. So thank you guys.